Well, welcome and thank you everybody for taking the time to join us. Fabulous to see so many of our local community leaders here joining the team delivering the county's vaccination programme. Particularly exciting is one of Boston's own returning home, a grammar school old boy and a very keen Boston United supporter. Welcome, Professor Van Tam. Now I'm going to hand over to Sarah Jane Mills, one of NHS's Lincolnshire's Chief Operating Officers, who has been an integral part of leading the county's successful vaccination programme. Sarah Jane is going to host tonight to ensure everything goes smoothly. Over to Sarah. Thank you.
Thank you, Councillor Skinner, and once again can I repeat our thanks to you, Professor Van Tam, for both joining us on this event and taking your time to come and help us vaccinate in Lincolnshire. I'm keen to get the discussion going, but ahead of that, what I would like to do is invite all of our panellists just to introduce themselves. So if I just start with myself, as Councillor Skinner said, I'm Sarah Jane Mills. I'm the Chief Operating Officer for one of the localities in the Lincolnshire Clinical Commissioning Group, and I've been working very closely with colleagues across Lincolnshire to support the rollout of the vaccination programme, which we're all very passionate about and keen to make sure is a success for local people. What I will do is now just hand over to colleagues who will be part of the panel so that they can introduce themselves, and then we will go straight into questions. So, Professor Ward.
Hi, I'm Derek Ward. I'm the Director of Public Health for Lincolnshire.
I'm Craig Kelly. I'm a GP in Swineshead and the Clinical Director for the Boston Primary Care Network.
Hello, I'm Linda Stockwell. I'm the Clinical and Site Lead for the PRSA Mass Vaccination Centre.
Hi, good evening. I'm Susan Ombler. I'm the Deputy Director of Nursing and Quality Governance from Lincolnshire Community Health Services in Lincolnshire.
Hi, I'm Michelle Howard. I'm the Assistant Director for Housing and Wellbeing for the Borough Council, and I've had a lead role in supporting and engaging our communities in Boston through the pandemic.
Good evening, I'm Rebecca Nino. I'm the Deputy Chief Nurse for Lincolnshire Clinical Commissioning Group, and have also assumed the role of Senior Responsible Officer for the system for the COVID-19 vaccination programme.
Thank you, and just as way of taking us into our first question, I'd like to invite Charlie Blythe, who is going to introduce us to a question that's been put forward by colleagues working in our hospital hub delivery unit. So Charlie, welcome.
Thanks, Sarah Jane. As Sarah Jane said, I'm Charlie Blythe. I'm Director of Comms and Engagement across Lincolnshire's NHS. So I've been fortunate enough to be involved in the vaccination programme in the county from the get-go, which is why I'm here. We've had lots of great achievements in the county to celebrate around the vaccination programme. But a key one is around our staff update, and they've been fab. They've really kind of risen to the challenge, and we've seen lots of them have their vaccination, but of course not 100%. And we've asked them, those who've been hesitant, why, and we've heard some real genuine concern and questions back from our staff. One of those is around fertility, particularly from female staff of a childbearing age. Can you offer any reassurance regarding whether having the vaccination could have a detrimental impact on fertility? And also, whether anyone undergoing or thinking about undergoing IVF should have any concerns about getting their vaccination, please?
So, Professor Van Tam.
Yeah, thanks. It's a common question, and I don't quite know where it's come from, the question about these vaccines and fertility. But I can say there's never been a vaccine that I know of that has affected fertility. And there's absolutely no evidence that this one affects fertility. And there's not really a good, sound biological reason why it would do so. So, you know, all I can just say, it just isn't true, and there just isn't a shred of evidence that could support it either practically or theoretically. But, you know, don't take it from me. Have a look on the British Fertility Society website. You can either go there directly, or you can go through the Royal College of Obstetricians and Gynecologists website. And they say exactly the same as I do, that there is just no theoretical or practical evidence for this. And on the point about IVF, which I understand is, you know, a very sensitive subject, and people don't want to do anything that's going to jeopardize their chances of having a child if it's difficult for them and they're considering IVF. But the answer to the question, can I have the COVID vaccine during my fertility treatment? Then the answer is absolutely yes. There is no theoretical or known practical reason why it should not be so. You could, if you wanted to, take into account that some people want to be sure they're protected against COVID-19 before they start something as delicate as having IVF. And so perhaps there are arguments to making sure you are vaccinated when you're called before you start that kind of treatment. But in terms of the kind of mixing the two, there's just no theoretical basis to have any doubts about that.
Thank you. And Susan, I wonder if you'd like to add anything from a local perspective.
Thank you, Sarah Jane. So absolutely, everything Professor Van Tam says. In Lincolnshire, the employers in Lincolnshire for our health and social care staff have got strongly established occupational health and wellbeing support services in place, which involves discussing on an individual basis with health and social care staff their concerns, their thoughts, and taking into consideration, you know, that many of these staff are at additional risk because of the roles that they undertake, but we need to have those conversations. So I would really just encourage staff who have any level of concern, talk to their employers. I'd also like to add that in Lincolnshire, we have a very strong Better Births programme of work, and the Better Births teams are fully engaged in our vaccination programmes. So if there's any level of concern at all, perhaps on a one-to-one, you can have a conversation with your midwife, with your hospital or your community team. I would just really encourage that. And just to follow up that, you know, pregnancy should be an amazing and exciting time for anybody, but we do understand that, you know, it's based on an individual basis, and you need to have those conversations, and we'd welcome them. And I know the Better Births team would as well. On another, we know that nationally that conversation comes up quite a lot as well. And we know that next week there are some national webinars going on. Also in Lincolnshire locally, we are going to offer in the next couple of weeks a collaboration. It's public health working with Lincolnshire, the Lincolnshire Care Homes Association, and the Better Births team are getting together to do some question and answers in a webinar basis, again allowing another opportunity just to raise that conversation. So many avenues to come forward and have that conversation. I welcome it.
Thank you. Thank you, Susan. So just building on the theme of pregnancy, I'd like to invite Jacqueline Windley to ask her question, please.
Hello, good evening. I've recently become a new nana. My daughter is breastfeeding, and I'm concerned that it's safe to have the vaccination while she's doing so.
Professor Van Tam?
Thanks for the question. There's the JCVI, that's our independent expert committee, joint committee on vaccination and immunisation, who the committee's been in existence now for 3 decades that I know of, so quite a long while, and they're totally independent. And we are, as a government, legally bound to accept their recommendations if they're practical and affordable to do so. So they have a kind of free rein to say and do what they think about all vaccines, the whole of the programme. And they're very clear about COVID-19 vaccines, that there's absolutely not a shred of evidence that they should interfere with breastfeeding in any way. And I wouldn't want anything to interfere with breastfeeding because it's so important. But by the same token, there is just no evidence and no recommendation that you shouldn't be breastfeeding. You should, even if you had the vaccine. Carry on is the answer.
Thank you. Thank you very much.
Susan, is there anything else that you wanted to just add? I suppose the other thing that we would say is encourage people to contact the Better Birth team.
Absolutely. Talk to your midwife, talk to your GP, or talk to one of our vaccination services. You're always welcome. I'd encourage that.
Thank you.
Lovely. Thank you. So our next question comes from Melanie Weatherly.
Thank you, Sarah Jane. As Charlie said, the uptake in health and care staff in Lincolnshire has been really good, and it's been a true representation of how we work together as an integrated system. But we would like to encourage 100% of those who can to accept the invitation. A key part of the feedback we've had regarding people who haven't accepted the invitation is about vaccine testing and safety. Could you please provide some reassurance to our teams that vaccine is safe and thoroughly tested? And what do you say to those who think that the process to get into the vaccine was just too quick?
Thank you, Melanie. And just by way of a bit more introduction, Melanie is the chair of the Lincolnshire Care Association, here tonight representing care homes and care home staff. So, Professor Van Tam.
Yeah, thank you. So I'll start really with the development of the vaccines and the clinical trials. The first thing to say is that they have been exceptionally big for clinical trials. They've typically involved, for each vaccine, 30 to 40,000 people around the world. So they're very big trials, and they're going to pick up any common side effects. It is true that if a side effect is very rare indeed, then you can't pick that up in a clinical trial. You have to wait until millions of people have been vaccinated. And we are now in a position where in the UK alone, we've now vaccinated 25, probably nearly 26 after today, million people with the vaccine. Some have had 2 doses, but mainly most have had 1 dose. And that vaccination program stretches now back to the beginning of December. And so were we to see any big safety concern, I believe we would have seen it by now. And yesterday's news from June Rain at the MHRA about the fact that they have looked at the blood clotting signal and found no overall excess is really, I think, a tribute to the fact that we are now getting very confident that there are no common or even fairly common side effects with this vaccine other than the ones we expect. And you can expect a sore arm, and you can expect to have a headache and feel grotty the next day, and that is completely normal and expected. And I'm telling that to every patient I see this afternoon, that it's normal, it's expected, it will pass, and you can take some paracetamol if you want to, but it's a lot better than having COVID. On the point about the speed of vaccine trials, one of the things that normally happens is that a company will go through phase 1, which is the first into man study of a vaccine. Then they'll get the results, then they'll present those to the board, and the board will say, can we see the commercial opportunity for these vaccines? And they'll think about it, then they'll okay the money to then plan and start phase 2. And so it is with phase 3, and it just takes ages. And it can take 5 years or more. On this occasion, governments around the world were pumping money into the vaccine development programs around the world and saying, we don't want you to wait. We want you to do phase 1. We want you to get people lined up so they're ready to take part in the phase 2 study if we get the right signals from phase 1. So literally there's a day we get the right signals, the next day we start phase 2. And then all the time that's going on, people are recruiting that 30,000 patients into phase 3, so they're ready to go the moment we get a good result. And alongside that, the vaccine manufacturers are practicing making the vaccines in very large scale, because you make a very small amount, just a few thousand doses for your first clinical trial, and use a very small bioreactor for that. And you've got to scale up and get to kind of, you know, big thousands of litre bioreactors, and it's not straightforward. Things can go wrong, things fail. And so all of that was done at risk. And I know all of the companies had made a lot of product that if the phase 3 trial had gone wrong and there was not a signal of good effectiveness, they would have just had to chuck it all away and go, well, it's our loss, we tried. And that's the kind of attitude that's been there. And that's why, quite amazingly, we've got vaccines basically a year after we first knew about this virus. But if we go back to the swine flu pandemic of 2009, had it been a new organism, not a flu virus then, we could never have done that back in 2009. We just didn't have the technology. But it's partly the amazing advances in technology that we've had.
Wow, that's amazing. Derek, did you want to add anything from a local perspective?
Yeah, just to pick up on one of the things JVT said there, the vaccine is massively better than catching COVID. And we've got to recognise that we've had between 125,000, 150,000 deaths in the UK due to COVID. In Lincolnshire alone, probably about 1,500 deaths, and the vast majority of those deaths are in the older adults. So that's just a very salient, very clear reason why everybody needs to get their vaccine. Older adults, we've had fantastic uptake, as Melanie and all of the care homes have done a phenomenal job in terms of making sure that we've protected our older population, care workers as well. But we need to get everybody who's offered a vaccine to ensure that they do get their vaccine, because that will protect not just them and their loved ones, but everybody else as we roll out the vaccine. So just to repeat, the other side of the equation, the very, very mild side effects, very rarely with the vaccine, but we do know that COVID is a killer, so we need to protect ourselves from it.
Lovely, thank you. And now our next question is from Karen Stendel. And if you'd just like to say who you're representing, Karen.
Yes, I'm a local resident and I work for Boston Borough Council. And my question is, another reason why people are worried about getting the vaccine is the side effects. Why do some people get side effects from the COVID jab? And does this mean that you have greater protection than someone with no side effects?
Good question, good question. Professor Van Tam.
Yes, so it is fair to say that we do understand that both of the vaccines we're using in the UK at the moment, and the Moderna vaccine, which we hope will join it in use quite soon, they do give you side effects. And you know, when you put a metal needle into somebody's arm, which you have to give them the vaccine via an injection, you will always get a reaction locally to the fact that you've put something into somebody's arm, mechanically, as it were. And so a sore arm and a bit of redness at the injection site is absolutely to be expected. On top of that, what you're trying to do when you give a vaccine is you're tricking the body to think it's been infected when it hasn't. You're tricking it and you're getting it to recognize the foreign protein that you're injecting, so that the body then makes antibodies and protects you against the real thing when you meet it. And these vaccines work by tricking our bodies to actually make the S protein, the spike protein that sits on the outside of the coronavirus. So once that goes into your arm, you make spike protein. Believe it or not, you actually make it. You don't make the virus, you just make the spike protein. And then your body's immune system says, I don't recognize that protein. It's different, it's new. I'm going to tackle it by developing antibodies. And antibodies are basically an inflammatory reaction. And also the T cells, other parts of the immune system flood into the area, and you get a sore arm, and you get some typical symptoms of headache, chills, muscle aching that last a few hours, and generally settle very quickly. You can take some paracetamol if you want. They are a sign that the vaccine is doing what it should be doing, but I don't want anything to, I don't want anyone to walk away thinking, well, I didn't have any side effects, so it can't have worked. That just isn't true either. We don't entirely know why some people have quite florid side effects and some people, they're quite mild. It is just part of the variation that goes with the vaccine. And the funny thing is that people get worried about the side effects they've had, and they start saying, oh, well, should I come back for the second dose? Well, it's very clear with the Oxford AstraZeneca vaccine that the side effects are lower with the second dose actually than with the first. So, you know, the opposite is true. With Pfizer, it's more of a mixed picture, and I couldn't say there's as clear a signal there. But with AZ Oxford, it's absolutely clear that the side effects of the second dose are lower than with the first.
Thank you. A number of people will be quite relieved to hear that. Right, I'm going to hand over to Linda to just say from our perspective.
Thank you. Thanks very much. What I'd like to do is offer that reassurance for people that are coming to the mass vaccination centres, because I'm sure it can feel a little overwhelming after being isolated for the best part of a year, and then all of a sudden you're in a room with a couple of hundred people. But at the vaccination centres, it's my absolute #1 priority to keep everybody safe. So we do make sure that there's good hand hygiene, everybody wears a mask, there's good social distancing. We very much listen to what our patients say as they come through the mass vaccination centres, and we act on anything that they raise to us. So here at PRSA, we're seeing over 1,000 people a day. We've vaccinated over 45,000 people just in our hub. So it's incredible what we're doing. It's very safe. And again, I would encourage everybody, come and get your vaccine, please.
Thank you. So our next question comes from Andrew Izzard. And again, if you just say who you're representing, that'd be really helpful.
Yes, good evening, everyone, obviously. So I represent Boston More in Common, which is mostly a Facebook group for the last year because running events has been almost impossible. And on the Facebook group, we've got around about 3,000 people, and they come from various communities. So they come from Latvia, they come from Russia, they come from Polish. So it's a really interracial group. And I suppose part of my question was coming from the confusion as to why, you know, this is a world kind of event and there's somewhere like 300 different places that are trying to create a vaccine. Certainly 85 are in testing. And to me, it seems like once you've successfully got one vaccine, it should be just spread through. So the question is, how many kind of different forms of vaccination are currently being used around the world? And what are the differences in the makeup between our two that we use currently in UK?
Okay, Professor Van Tam.
Yeah, thanks for the question. The two vaccines we've got in the UK at the moment are the Pfizer vaccine and the Oxford AstraZeneca. The Pfizer vaccine is a new technology vaccine using messenger RNA, and it's basically a direct injection of messenger RNA, which is coded so that when it goes into your muscle and your deltoid, it tricks your muscle cells to make that messenger RNA codes for the spike protein on the coronavirus. And you make locally in the muscle some spike protein from the coronavirus. And your body then recognizes it, the immune response happens, and you get antibodies to it. So that's the messenger RNA technology. The Moderna vaccine is going to be exactly the same technology. And there are various other messenger RNA products that are coming through, some of which the UK has invested in, and we should get those products in the fullness of time, sometime later this year, I'm imagining. The Oxford AstraZeneca vaccine is a different technology. It's called an adenovirus vector. And what you do with an adenovirus vector, and it's the same as the Janssen vaccine, which we hope to have towards the summer, and it's the same as the Russian Sputnik vaccine as well, and it's the same as some of the Chinese vaccines. And basically, you use an adenovirus, which is a harmless virus for humans. You genetically modify it so that it cannot multiply. And then you put a piece of DNA into the adenovirus. And that piece of DNA also codes for the spike protein on the coronavirus. And once that gets into your muscle cells, again, it's the same final pathway. You produce the spike protein and the body recognizes it and you get an immune response. So in this case, really the adenovirus is like a taxi, and the coding that we need to make the spike protein is just hitching a lift inside the body on the adenovirus. And that's how that one works. And that's the technology that we used to get the Ebola vaccine. Now, there are some more coming through, and the big ones coming through are what we call protein subunit, which is basically all the spike protein from the outside of the coronavirus kind of sloughed off and put into a vaccine. So instead of you creating the spike protein, you're injecting it directly, usually with an adjuvant, something that makes the immune response a bit stronger. And those vaccines are coming. The leading candidate is Novavax, but they're not quite ready yet. And then finally, and further down the kind of timing, are the whole virus inactivated vaccines, which is basically the whole coronavirus smashed up into bits and killed and then turned into a vaccine. And that's quite an old-fashioned technology, but it might in the end be better and might in the end give broader protection against the variant viruses that we know are coming along, you know, the Brazils, the South Africas and so forth. Because with that vaccine, you don't just get the spike protein on the outside of the virus, you get all the bits inside as well. So the immune response you create is perhaps a bit broader in the end and a bit more long lasting. But those vaccines are not available yet. But we've invested in all of the technologies I've told you about, and we should have, in the end, access to, if they all come through, and they may not all come through, 357 million doses of vaccine. So choices, and we may need them. We may have to revaccinate in the autumn.
Okay, that's blown my brain, all that technology. Rebecca, I wonder if you want to add anything from a local perspective, please.
I can, Sarah Jane, thank you. So from a local perspective, we have access to 2 vaccines currently. We have the AstraZeneca Oxford vaccine and also the Pfizer vaccination available. We don't know which vaccines we're necessarily going to get week on week. These are pushed to us nationally. So on the whole, we tell our public there is no choice of vaccination because we don't actually know what's available at the centres week on week. However, what I would say is if you do require a specific vaccine for a medical reason, your GP will work with you to find somewhere within the county that is administering that vaccination. So there's no need to worry that you won't get access to a specific vaccine if you need it for a medical purpose.
Thank you.
Okay,
So
could I just come back in?
Yes.
And say that, in my view, the AZ vaccine and the Pfizer vaccine are both really good. It's really difficult to split them apart in terms of the effect they are having on reducing hospital admissions, which is well over 80%. It's very difficult to split them apart, even after the first dose, in terms of the infections they're preventing, and that's typically 60 to 70%. So they really are astonishingly effective vaccines. And I wouldn't have cared whichever one had been given to me as it happened. I happened to have the Pfizer. It was available on the day I started my vaccination clinics, and that's what they gave me. But I didn't really care at all, to be honest with you. And I did the count just before the number 10 press conference on Wednesday, in case anybody asked me. And across my extended family across the UK, it's about 50-50 in terms of which vaccines we've had.
Thank you. I think the message there is, if you're offered a vaccine, don't worry about what type, just take it. And I think that's really, really important. Graham Wright, I wonder if I can invite you to say where you're from and ask you to ask the next question, please.
Hi, yes, I'm Graham Wright. Thanks to the panel for tonight. I'm the head teacher at Sibsey Primary School, and I'm representing what we call the Sibsey family, so the children, the parents and the staff of Sibsey. So I've got two quick questions for you tonight. And the first one is, perhaps you could explain the rationale as to why school staff weren't initially prioritised for receiving the vaccine, because I think there's been a little bit of confusion, and I think a bit of clarity and the rationale behind it would help clear that up for people.
Shall we start with that one as a starter then?
Yeah, very happy to answer that question indeed. And look, I think it's a reasonable question, and I think it's reasonable for teachers to ask it. And, you know, say, well, look, I'm working in a classroom with loads of kids. It's very difficult to socially distance from them sometimes. And, you know, I feel at risk. What the JCVI has done is it has said we must begin our vaccine programme in a way that saves lives and the maximum amount of lives. And you've seen how bumpy vaccine supply can be. We have to start with the highest need groups and work downwards, as it were. And that was very clearly the list that they issued for the phase 1 of the programme, which, as you know, began with the elderly in care homes, and it worked its way down the ages and has now got to the point where we're offering 50 plus. And the JCVI did that because they looked at all the risk factors, and they did look at occupation as well, although obviously occupation is less relevant once you're 65 plus. And the big risk factor was age, followed by age, followed by age, and then followed by chronic illnesses. It was literally that stark that the only thing that needed to be taken account of was age, frankly. And that's why we started where we did. Now we're getting to the lower age groups, and we're thinking that I guess in the next couple of months we'll be able to start what we call phase 2 and go even lower. There has been pressure from occupational groups such as teachers to say we want to be prioritised. But the government has continued to say to the JCVI, what we want you to do is save lives, and then after that stop hospital admissions, because if we can keep the NHS from falling over, then we can all go back to a normal life. And they did look at occupation, and there are some occupations which are at higher risk for sure, but teaching, it was not at the top of it. And even then they said, look, the quickest way, you've seen how fast the UK can go compared to Europe on vaccination. The quickest way is to keep it really simple and just do it by age. And I think that's what's going to happen in phase 2 as well. But I've got some stats for you because I don't want to give you flannel. The ONS has looked at teaching and educational professionals aged 20 to 64 between the 9th of March and the 28th of December last year. And the death rate from COVID, let me get this absolutely right, in male teachers was 18.4 per 100,000. And if you compare that with males of the same age band in the general population, their rate was 31.4. So teachers are 18 and male teachers 18 and males generally 31.4. For females, the female teacher death rate was 9.8 per 100,000, and across females of the same age in the general population, 16.8. So the JCVI could not say that teachers should be prioritised based on their risk of dying. And had they gone down the kind of occupational route, they would have started with warehouse workers, taxi drivers, security guards, and some quite unusual occupations. And it would have been very slow to find them, and it would have made the programme very, very slow. Sorry, that's a long-winded answer, but I wanted to give it to you completely.
No, I think that's really, really helpful, and I will just bring Derek in, and then I'll come back to you, Graham, because I think you've got a second part to your question. So, Derek.
Not much to add to JVT's answer, just a little bit of the numbers in Lincolnshire over the past 7 days. We've had, lost my figure, 630 positive cases in Lincolnshire, of which 36 are in the 4 to 11 year age band. And there was a paper published last night, actually, that suggests that the vast majority of children, young people, and indeed teachers who do catch COVID tend to do it outside of the school setting. So all of the practical reasons JVT's covered, but in terms of COVID, when children, young people do get it, it's a very mild disease. We're not sure, but it's quite likely that there'll be less infectious as well. So there's lots of reasons why we've not prioritised teachers over any other group. But the real driver here is about getting as many people vaccinated as quickly as possible. And that's simply go by age and work your way down.
Okay, so you've got another question for us.
Yes, thank you both for that explanation there. That clarifies it very nicely. So the second part is just that I've seen there's an NHS FAQ document called lateral flow antigen tests, and really my question is around how school staff and I suppose other professionals will be expected to continue to take lateral flow tests once vaccinated, according to the document. So I just wondered if there's any insight into how long staff may continue to need to take the LFTs into the foreseeable future, or is it a bit early to tell?
It's a very good question. I think it's too early to tell. We want information that these vaccines are not only preventing infections and deaths and hospitalizations, but they're also preventing transmission. We have got some data on that now, but I don't think we feel yet in the fully confident space. I can tell you that they are going to prevent transmission. That's not really in debate for vaccines that are 90+% effective. It's the amount of transmission they're going to prevent. And I think we don't know that yet. And I think if teachers and children, particularly the teachers, keep on doing the LFDs, as we are asking them to for a while longer, we might start to get some of those answers. What I can tell you is that there's a new preprint paper came out on Monday, I think, from Health Protection Scotland, and they are studying their healthcare workers who are vaccinated very carefully. And after the first dose of vaccine given to a healthcare worker, the risk of infection in the household members of that healthcare worker who are unvaccinated after the first dose has already gone down by 30%. So that's an astonishing result after one dose. And it does give us real hope that we are going to see more and more evidence now that these vaccines will prevent transmission. And if they do, they're going to lead us much more quickly into a safe world.
That's what we want to hear. So, still with the school, can I invite Lucy Hayton to ask your question again? If you'd just like to say where you're from, Lucy.
Good evening, everyone. My name's Lucy Hayton. I'm an assistant head teacher at Haven High Academy in Boston. And my question is very much linked to Graham's previous question. As we know, all students have been back to school for 2 weeks now, and bubbles across the country are already starting to burst. At what point will it be judged that the vaccine rollout has created enough immunity for it to be unnecessary for students to isolate at home if they've been in close contact? Essentially, when does the balance of opportunity cost tip towards students' education being more at risk than the possible transmission of COVID-19?
Thank you for the question. I mean, look, I'm completely in favour of getting the kids back to school, and you know, my 12-year-old was, who's only been back the same amount of time as everybody else, was absolutely distraught when his test and trace app fired off and told him he had to isolate. It then turned out that it turned green suddenly, and he didn't in the end. But you know, he wants to be at school, and they all want to be at school, and it's not good for them not to be. So we're not worried about children, as Derek said. We're not worried about COVID-19 infections in children because they tend to be mild and non-serious. What we are worried about is children going home and spreading the infection and moving it between households, because that basically the contact between the household is via the school. As we get to a position where more and more families are being vaccinated, parents, we're going to get into a much safer world where it's going to matter less and less about infections in children. But we're not there yet. We've only got to offering the vaccine to 50s and above at the moment. It's going to take a while longer. And remember that it's a 2-dose vaccine schedule. And I keep reminding people of this, that we might be down to the last group of phase 1 of the vaccine program, but that's giving that last group their first jab. We've got to go back and do it all over again to give them each person 2. So it's just going to take a while, Lucy, to get into that safe place. And it will be a value judgment about how much disease there is in the community, how much disease we see through the lateral flow testing, vaccine uptake in the slightly lower age groups. It'll be a kind of balance of things. But yeah, I really think we're going to get there. So it's not forever.
It's very encouraging. Derek, I wonder if you want to add anything else?
Yeah, I'm really hopeful we'll get there sooner rather than later as well, Lucy, because as you know, all schools, whether primary or secondary, have been testing for staff, but we've been testing in secondary schools for students as well. In Lincolnshire, since the beginning of the year, 21, we've done more than 100,000 tests, lateral flow tests in children and young people, and we've got just about 100 positives. So that's a 0.1% positivity percentage. So very, very little disease that we're seeing in that age group. And in terms of coming back to Graham's question, in terms of the teachers as well, we've done a bit more. We've done nearly 110,000 lateral flow tests in teachers, and we've got under 200 positives. So it's a 0.18%. So it's looking good. But the whole point of lateral flow testing really is to case find. It's trying to find early anybody, especially children, young people who might have very, very mild symptoms or no symptoms at all. It's trying to catch those early, make sure that they don't pass it on and we don't get outbreaks in schools. And as you'll know, we have got outbreaks in schools and we'll continue to get outbreaks in schools. But we're here to help. We've got a health protection team that are on the end of the phone and will help try and minimise the impact on children's education.
Excellent, thank you. And now I'd like to ask George Bell, if you'd like to ask your question again, if you could just say where you're from, George.
Thank you. Yes, George, but I'm from Boston College, the mysterious place beyond the school fence. And I specifically work in the area between education and employment. So wanted to look at what we could perhaps take from this experience. Given the correlation between other health conditions and the COVID risk, what would you like to see us do to improve the wider health of our community in future, with particular reference to changing the mindset of the next generation as they leave school and college?
That is a really really difficult question. I remember the snowball fights with the college kids at the bottom of the grammar school playing fields when I was a kid. I think one of the things we've had to face in the UK is the fact that we've taken quite a big hit from COVID, as have many countries in Europe and the United States. And we do know that obesity is a big risk factor for COVID. It's really quite a big risk factor for a bad outcome. We also know, and I'm going to pass to Derek in a moment, that you know, being overweight is associated with so many other health difficulties as we go through life as well. And I think that's a big thing that we will need to come back to in the post-COVID world and think very seriously for the next generation about what that means. I'm going to stop there because I think you need a Director of Public Health to give you probably a better answer than I can give.
So Derek, you're on the spot, and then I'm going to come to you, Michelle, as well for some thoughts from you. So Derek.
Well, I think Michelle and I can do a bit of a double act because we've been working with our district councils before COVID. Of course, we were. It's sort of the job of our lifetime to make sure that we are tackling the wider causes of ill health. But JVT's picked up the key one for us in Lincolnshire, which is around obesity. It's around, in terms of, we know physical activity, particularly for girls and young women, when they move between schools and from school, secondary school into college or university, there's a real risk there that we'll lose them. If they're physically active in school, if they're playing netball, if they're playing football, whatever it is, there's a real risk that we lose that. So one of the areas we want to focus on is to make sure that our kids and our young people carry on physical activity right the way through their life. And then at the other end of the spectrum, we're looking very much at working with the Centre for Ageing Better, and Lincolnshire is one of the key partners, to try and keep people fit and active in their 50s so that they can keep working if they want. And if they're going to retire, they'll be active in their retirement. Maybe they'll volunteer, because we'll be stopping some of the diseases that we tend to see in that age band. So yeah, absolutely obesity, number one priority for us now. But we're breaking that down to different bits because it's quite hard to get people to change their diets unless you can get the entire family to change their diet. It's more likely, especially in younger people, that we can instill a real love of physical activity. It could be sport, or it could just be walking in the countryside, and we've got fantastic countryside coastline in our county. So it's about keeping that going for people who've maybe discovered that through as we come out of COVID and into recovery. But I'll pass over to Michelle.
Thank you, Michelle. I think our vaccination programme has been very much a partnership, and I think it builds on that foundation. So would you like to add anything to what Derek said and just expand a bit on what else is happening?
Thank you. Yeah, I think I'll come at this sort of build on Derek's response from a community engagement perspective. And first, George, just sort of thank you for recognising the importance of everybody playing their part as we come through this, and not only now but in the future. And my reflection really is about how do we work with our communities so that we understand actually what some of those concerns or barriers might be, whether that's around vaccination, whether it's about health more generally. And working with is the really key word there, because if we can work with and get those proper relationships and proper understanding, actually we can find ways to try and sort of overcome any of those concerns in the future. And I think we need to recognise that actually as professionals, we don't always have the answers about what works in really engaging our communities and really getting underneath actually what's going to make the difference. So I guess our offer to you, to George, for the college and the schools and any other organisations in the area is that we'd love to work with you, we'd love to explore those opportunities, and we'd love to give our young people a voice to help us decide, you know, really what will work in the future.
That's brilliant. Thank you, Michelle. And I think this is testament to the fact that we see this as a very much a community response. So I'd like to now invite Liz Hopkins to take us on to the next question, please.
Thank you very much. My name's Liz Hopkins and I'm the Chief Executive of Centrepoint Outreach. For those that don't know, Centrepoint Outreach is a local Christian charity and we support homeless and vulnerable people in Boston. And as part of our work, we've come across some EEA nationals who are not registered with a GP, and for whatever reason, they're very reluctant to register. So my question is, will people who aren't registered with a GP still be able to access the vaccine, and how will they be contacted about it?
So thanks for the question, Liz. I mean, I can only give a kind of central government answer, as it were, and it's absolutely categorically policy that every adult living in the UK, when they're called in the priority order, is entitled to a COVID-19 vaccine, or 2 vaccines if it's a 2-dose course, free of charge, completely irrespective of immigration status. There's nothing that's going to ever be linked to immigration checks. The NHS is not required to pass on any information to the Home Office. You don't need an NHS number to make a booking for a COVID vaccine. And we are making sure that the programme is available even if you're not registered with a local GP. Now, there has to be really good community outreach to make sure that it's clear to all of those communities that it really is so. And on this really important public health battle, we are making no distinction by nationality, race, immigration status, or anything else, merely on the priority order. But I'm sure the local public health team, that will be something they would want to say more on and reassure you about.
Thank you.
Well, I'm actually going to take us to one of our local GPs. So, Dr. Kelly, not only are you a local GP, but our clinical director for our primary care network and very close to your local community. So I just wonder what your thoughts are to Liz's question.
Yeah, this is a really important point for our locality and our population. We've seen this in other long-term conditions. I think COVID has actually brought it to the forefront. And I suspect in the future, because of the bridges we'll build, that we'll be able to address their health needs for that. From our point of view, yesterday, in fact, we created a film by one of our Polish doctors, which is being distributed to all practices in the CCG in Polish and in Lithuanian and various other languages, so that then we can try and use social media to get out to people. And it's word of mouth. I think as a PCN, what we thought about doing in the future is maybe even going to some of the local employers and factories and have roving teams to go and address that issue. And I think that's the way forward, is the mass vaccination sites and the local vaccination sites to look at different populations. But that's what we're doing. It is a problem, but we've got it in hand. The homeless is another issue, which is a big one. And I think we've set up a small working party within the PCN and the neighbourhood team to look at this issue. And we're going to triangulate the findings that we have with people like Centrepoint and so on, because we know that all the databases are a little bit muddied and we need to have accurate information and numbers, but it's something that we're working on.
Thank you. And I just wonder, Rebecca, whether you wanted to say anything more in terms of if people aren't sure what to do, how they might access the programme.
Thank you, Sarah Jane. Yes, I mean, as we've already said, you don't need to be registered with a GP to access services, particularly at the mass vaccination sites. So people can dial 119 free of charge to make an appointment at their mass vaccination centre, or they can log on to the internet through the national booking system to make an appointment as well.
Brilliant. And this is a real opportunity in terms of this programme, isn't it, to encourage those people who aren't registered with a GP to actually take this as an opportunity to make contact with local process. And I understand there's quite a simple process in terms of being able to register with a GP through the internet. So I think both encourage people to access the programme, but also this is a great opportunity for us to connect with people and encourage them to register with GPs. So the next question comes from Robert Oldershaw, and I'd like to hand over for you to say who you are and where you're from.
Thank you. My name is Robert Oldershaw. I'm from Molson Bulb Company. We're a local food producer, and we employ over 200 Eastern European workers. And talking to a lot of them, there seems to be a real fear of the vaccine among that community. Other than the promotional material that I've seen for the Asian community, what else will the government be doing to encourage the take-up of the vaccine among groups who are more likely to be fearful?
Professor.
So I think the government, well, I will say the government already knows that it's important to leave no one behind in this programme, and we don't intend to leave anybody behind in the programme. But we do recognise that the levels of understanding and levels of suspicion or fear about vaccines will vary in terms of different ethnic and minority groups in the UK, and we are already seeing that difficulty. And it's really down to understanding what people's needs are, being ready to let them take their time to make their decisions, accepting that they won't all just come forwards all at once, making the service as accessible to them in a way that is meaningful to them as well, and making sure that the funding is there for that. And I think the government has committed, I think it's £23 million to 60 councils and voluntary groups across England now to try and allow local schemes to reach hard to reach groups. But we are going to have problems if we don't just persevere and continue to try and get to those hard to reach groups. And we must all adopt a mentality, however long this goes on, of that it's never too late to have your COVID vaccines. And I think it's never too late is going to be something that we have to keep on saying between now and Christmas.
And Michelle, I think we're one of the areas that are really actively involved in this programme. So I wonder if you'd like to add anything.
Yeah, absolutely. We're absolutely delighted that Boston's one of the areas, and one of the things that we have been so proud to be able to do is to very quickly develop a community leaders network, of which all of the people asking the questions tonight are a part, and a really important part, because actually hearing and understanding those real views and what's actually happening in our communities, that's the only way we're going to be able to make a difference. So, generally, thank you, Robert, for the question you've asked. And sometimes, that feedback helps us to realise that the way in which we thought we needed to do something might not be quite right, and we might need to be a little bit more creative. And I just want to reflect on the videos that you heard Dr. Kelly talk about a few minutes ago, because that's the kind of thing that actually we can make available to employers. I know when we had the community testing programme, we had videos playing in canteens, in workplaces, we had information going out with pay slips. And sometimes, that might be all it takes. And other times it might be that actually we need to create an opportunity where people can come together and actually ask those difficult questions, and have those answered by somebody that they trust in their community, that they will really listen to and follow the advice of. So again, that offer through that Community Champions Network is be honest with us, tell us what's working and what isn't, because that's the way that we can try and make a difference in the future.
Thank you, Michelle. Now, I hope people will indulge me, but we are reaching 7 o'clock, and I know we hoped we might be finished, but there's such richness in the questions that I'd like us just to carry on with the final few. So in that spirit, I'd like to invite Bridget Lloyd, to ask your question, Bridget.
Thank you, Sarah Jane. I represent Lincolnshire Housing Partnership. We're a social housing provider in Lincolnshire and particularly in Boston. Now, some of our Eastern European tenants are raising concerns about the safety of the Oxford AstraZeneca vaccine after speaking with family members in their home countries, where these concerns seem to be heightened. What can we as a landlord do to help with this?
That's a very difficult question indeed. I think that one of the problems we have with communities who still listen to the news in their own language and listen to the news in their from their home countries as they want to, and as perhaps they should do, they are exposed to different messages about vaccination. And, you know, it is very challenging when they hear something that just isn't right and just isn't true about vaccination, particularly about the Oxford AstraZeneca vaccine. And I really don't think what has gone on in Europe recently in terms of, first of all, the reluctance of countries to use it in the elderly, and then, you know, various adverse comments by European politicians about the Oxford AstraZeneca vaccine, all of which are just completely unfounded. What we need to be doing is just pointing them to the fact that Europe is experiencing a third wave of COVID-19, and really quite a dramatic upturn in many parts of Europe now. The UK is on the opposite trajectory. And the reason we believe we're on the opposite trajectory, and there's now proper evidence for it, is the strength and depth of our vaccine programme, which, you know, for which AstraZeneca Oxford is one of the mainstays. So I just think we've just got to continue to press our message that the vaccine has been properly evaluated by one of the most stringent regulators in the world, the MHRA, and that they, all people have to do is look around them and see the evidence that the vaccine is now working and starting to change our lives.
Thank you.
Thank you. Linda, I wonder if you wanted to add anything before, again, I invite Michelle.
Yes, please. What I would like to say is that on behalf of the local vaccination team, if there's anything that we can do to help or support or answer questions or try and buff those myths, then please, you know, call on us, because we'd be delighted to help and see our community kept safe. Thanks.
And Michelle.
Yeah, my reflection on this is that as a landlord, you play such a valuable role. And the reality is that sometimes you are engaging with residents in our communities who are not engaging with any other services or any other professionals. So actually, you've got an opportunity to get some of that information to people that we may not otherwise have. So I think the offer from Linda there is a really important one. If there's anything that we can be doing within communications you send to your tenants, any engagement or interaction you have with your tenants, any opportunity to do some of that myth busting, but also to build some of that trust and confidence, we'd really, really welcome that. And, you know, we know housing is such a key part of engaging with people for lots and lots of things. And I guess there's a real open offer there to work in partnership with you to really support your tenants as well.
Thank you all.
Lovely, thank you. So in moving on to the next question, I just want to really demonstrate that this is a Lincolnshire community question and answers, and just point out, and I know you do because you recognised each other, that Ben and Jonathan actually went to school together, and I think we may even have a picture that proves the points. So Tom, do we have that? There we go. Can we spot you?
Yeah, I recognise it. I'm in the red jumper and Johnny's just stood behind me. So
I'm just above him.
Yeah, you are.
Tearing above me. Spot each other. Yeah.
Yeah. Good day, Johnny. But from a lad from Boston, we're so proud. The community is so proud of what you've done, what you've achieved, and the way you come across and put it in easy language for all of us to understand. Somebody that hasn't got a medical background, I think it's fantastic. We understand exactly what we've got to do as people to make us everybody safe. And the question I have is, now the vaccination is on the way, is it something that we're going to have to do on a regular basis, like the flu jab?
Thanks, Ben. It's lovely to see you again.
And you, mate.
Yes, yeah. The truth of the matter is that we're not quite sure yet. there are two reasons why we might need to give the vaccine again. One is if the protection from it wears out after a certain time. Now, we know that some vaccines, you give them in childhood and the protection basically lasts you a lifetime. But we also know there are other vaccines, like the flu vaccine, good example, where it basically wears out. Now, with this one, we just haven't had the vaccines long enough to know how long the protection is going to last. My guess is that the way the antibody graphs look, probably, if that was all that was at stake, then they would probably last about 2 years. But as you know from the news, the virus is changing. And so we've had the Brazil variant, there's 2 Brazil variants, in fact, and there's the South Africa variant as well. What we don't know yet is whether the vaccines are always going to protect against these new variants that are coming along. And so we could have to revaccinate because of the new variants, or we could have to revaccinate because of protection wearing out. And probably we won't have to revaccinate the young as often as we have to revaccinate the older people in our society. So I'm hedging my bets because I don't know the answer. And you know me, I don't like to give an answer if I don't know it. I like to say I don't know. But my guess is that we probably are looking at some degree of revaccination in the autumn. My guess is that it's more likely to be the older age groups than the younger age groups, because let's not forget, the very younger age groups, they're not going to be getting their vaccines for a few more months yet. Whereas the very elderly groups started to have their vaccines in December and January. So again, they're going to be the people, I think, who it's most likely we'll have to go back to before next winter.
Awesome. Just like to also add, Johnny, it's great to see you, Boston United supporter, passionate about Boston United, and wearing that tie is fantastic. You certainly put Boston and Boston United firmly on the map, mate. So proud of you, mate. Well done.
Thank you for that.
Thanks for what you've done.
It's an enormous pleasure to be back in Boston, to be able to help with the vaccine programme, and I'm very proud of being from Boston, and very proud of my roots.
Yeah.
Very proud that I grew up here, and many of the lessons in how to put things over to people I learnt on the streets of Boston or in the Boston Grammar School, and that means a lot to me.
Yeah, you certainly put it across very well, mate, and I understood it well. So thank you very much for that.
Yeah, I would echo that. I think it's been really helpful. And I just before I take the liberty of sneaking my own question in, I just wanted, Susan, if you wanted to say anything about the Lincolnshire position in terms of if we do have to repeat or do booster jabs.
Thanks, Sarah Jane. So whatever the future brings, as the Professor says, we're ready. We're in a great place. Every year, we head into winter, we deliver rapid flu vaccination programmes. In fact, in Lincolnshire this year, we're running the top of the league in the Midlands League and have done phenomenally well with all of our providers for health and social care and the public. Phenomenal delivery. And then not only that, we then switched direction and delivered a phenomenal COVID vaccination programme and continue to do so. So I think, that alongside what we do already, we do school age immunisation programmes, other vaccination programmes, we'll be fine. And whatever the future brings, we've got a good track record. We're very proud of what we've done this year, both for flu and vaccine, and that's going to continue. So see where it comes.
Thanks, Susan. And as you say, really proud and think vaccinations are really important in terms of keeping people well. So the cheeky bit is I wanted to sneak my own question in. It was announced on the 17th of March that the UK would experience a reduction, quite a significant reduction in vaccine supply from the end of the month, which would last throughout April. And people were advised that they won't be able to book first appointments during April. I think that means two things really for me. One, it means that people who are under 50 face the prospect of having to wait until May, and I know that will be a concern, but also will there be a delay for those people who are due to have their second jab? Because obviously the information that we have is that there needs to be a 12-week gap between the first and second. And if there was a delay, people would be worried in terms of, or I would be worried in terms of whether it would be less effective if it was given after the 12-week period.
Thanks for the questions, really good questions. So the first thing to say is, yes, obviously you're aware that supply can be lumpy at times, and this is because there is now a very significant international demand for these vaccines. We are so lucky in the UK that the Vaccine Task Force got ahead of the game and got the UK's vaccines ordered in very quick time, and that's why we're in such a good supply situation compared to so many other countries, even though we are going to run into a lean patch for a while. On the under 50s having to wait a bit longer, that may be a consequence of where we are right now on supply. But if you think about the over 50s as a whole group, 99% of all the deaths that are occurring from COVID in the UK are occurring in the over 50s. So safeguarding the programme for the over 50s is the most important priority. And Emily Lawson, who leads the NHS vaccination programme from the Department of Health and Social Care, I know that she obsesses about the numbers of vaccines and the supply projections, making sure that we are going to be able to cover those second doses that are booked in already. So I'm actually quite confident that she's got that very well nailed, and that we will have the supplies for the second doses for phase 1, and that there won't be any problems. But I would say to you that on a kind of primary immunological theory basis, actually it's well known in the vaccine world that the longer you leave between the first vaccine and the booster dose, the better the response is going to be to the booster dose. And we know already that the first jab alone is giving us sustained protection of 60 to 70% against infection and 80+% against hospitalization. So nobody likes to have a date and then you know it's not met and you kind of get all anxious about another week, another 10 days. But really, in immune system terms, it is absolutely nothing to worry about. And one of the things we've done with through the JCVI with the Oxford AstraZeneca programme is now make the minimum interval between the two doses 8 weeks when it was previously 4 weeks. And the reason for extending that and making the minimum longer is because there's now clear evidence that waiting a little longer for the second dose of Oxford AZ is actually better and gives you higher protection in the long run. So for all of those reasons, if it comes to the fact that you're not called bang on your day for the 12 weeks, please do not panic about it. Your immune system is kind of on your side in this circumstance.
Great, thank you. Rebecca, I wonder if you want to say anything about our position in Lincolnshire.
Thank you, Sarah Jane. Yes, I can. So the line of sight that I have on second dose vaccines does demonstrate that they will flow into Lincolnshire. So I just ask people locally not to panic. As you've heard Professor Van Tam say, the national team are absolutely committed to ensuring second doses are absolutely available. So, and that is the line of sight that I currently have. So hopefully we will be in a position to honour all of those second dose appointments. We also expect to have some small amounts of supply available for first doses, which is a really good position to find ourselves in. Those first doses during April will be focused on this revisiting of cohorts 1 to 9. So that will be our absolute focus during April. We will be working to increase uptake and driving uptake, and much of that we've discussed this evening around some of those groups where we still have work to do. The programme success in Lincolnshire has been phenomenal so far. We've got over 90% uptake in those over the age of 65. And we've got increasing rates of uptake in those between 50 and 65. And I see those numbers move in the right direction daily, but we still have more to do. And that is going to be our absolute primary focus. And once the vaccine starts flowing in more volumes again, we are stood ready to stand up our services in Lincolnshire and vaccinate the under 50s, and we look forward to doing that.
Lovely, thank you. And then we're moving to our final question from Councillor Deborah Evans. So, Councillor Evans.
Hello, thank you, Sarah Jane. I just wanted, I'm a councillor for the Stanleyland ward and the current deputy mayor, so I'm very lucky. And I just wanted to say, well, Ben, I think we all agree strongly with Ben. That was so well put, Ben. You brought a tear to my eye then. That was lovely. My question to Professor Van Tam is, have you been impressed with how all the communities in Boston have all come together to deliver an impressive vaccine rollout? Thank you.
This is my first time at the vaccination centre at the rugby club, and it's absolutely fantastic. It's a really well-oiled machine. The throughput is very high. It's a nice, slick operation. The staff are really friendly. It feels safe and socially distanced. It's just great, and it's great to meet so many people from different walks of life, and makes a real change from working in London.
Brilliant, and that brings us to the end of all our questions. On a personal basis, I just want to say a really big thank you to yourself, Professor Van Tam. I think, as Deborah said, Ben summed it up really well. All of the answers have been really clear and really understandable, and that's really appreciated. And I have to say, on a personal basis, I've learnt loads this evening, although I'm really close to the programme. I would also like to say thank you to everybody who's asked a question. There's been a real richness and it's covered a whole range of issues that I know will help us encourage people to continue to take up the vaccinations across Lincolnshire. And for you, for your continued support in making this a real community effort. And finally, to our panel members who have supported us. And I'd also like to say a really big thank you to the people that are behind the scenes. We often forget them, but colleagues from our Health Watch Lincolnshire who have helped us organise this event, and colleagues from our communication team across the Lincolnshire community. A really, really big thank you. Without all your hard work, we couldn't have had such a great evening. So I'd like to hand over to Councillor Skinner for any closing comments. Councillor Skinner.
Well, thank you very much, Sarah Jane. I've been involved with this since it started, and just as Jonathan's had his Boris homework, we at the local council level have had ours. You know, how do we go and actually make it work in the community. It's been an absolute pleasure to see people working together for the benefit of the community throughout. And we've faced many challenges, but around this part of the world, we can lift ourselves up to them. So I'm very happy, and thanks everybody for taking part. Thank you, Sarah.
Thank you very much. And it just comes to me to say good night.